düşünemiyorsun bu görüntüleri fix masayla alacağız. Daha iyi olur öyle. Okay. So good afternoon again. This is the second case of the CTO workshops we do. This patient is 65 years old patient. He has diabetes and hypertension as risk factors. He had the CABG operation in 2003 for 4 vessels. Currently he had stable angina. He had Lima LAD is open, but the other graft is not visible. The other grafts are occluded. And the patient has sent us for RCA CTO, and the RCA is occluded from the ostium. You will see it now, and we have nice collateral from the left. We have a couple of septals there, and many of them goes to RCA. Next, please. If you come back, next, please. This is left system from spider. This is right injection. We use here LA1, and you see that we don't have any stump. From the left, we have filling. The CTO shouldn't be that long in this view. If you see here again, okay, so this is the case. Next, please. Another spider view. Next, please. So let's see here. We have 3 septals. All of them may go radial. We will check. I think the third one looks to me better. We will check now. Right cranial. Yes. Let's see from here as well. Here is good. Yes. Cranial. Okay, let's see. Fixed. Right. So, lots of branch, but obviously one of them goes, yeah? None of them, it doesn't mean that all of them will go this way. But I try to go with the third one. Yes. And I like to have Corsair. 150. And then BMW inside. Corsair. So, do you have any questions, friends, regarding the case? Can you hear me? And we are doing this case, sorry, with my friend from Jordan. He joined us from Jordan, Nail, and the surname was? Shoba. And I have my fellow Ahmet Shakir from Syria, and I have nurse Ur and technician Abdurrahim. Can I have the BMW wire? What we do now, to go septal, we have Corsair, and inside we will have BMW as a workhorse. After engaging that, I hear my voice. Can you correct it, please? Okay, so let's go spider to go LAD, and then hold the wire, please. Yes, Nail, hold the wire, please. And go up there. We are in the right, yes. We need to go to left. We will go to left instead of right. Can you come back, please, a little bit? More, yes, inside the micro. Thank you very much. Okay, hold the wire, please. Thank you. So, can you tell me the ACT, please, now? Okay. Can I have Corsair? Torque, please. Torque. Yes. Thank you very much. And now, can I have a test, please, here? This is the third one, I believe. Let's do a tip injection. 2 ml syringe, please, for me. Let's do it from here. No, that's okay. Yeah. No. So can you remove it, please, for me? Remove the wire.
The wire?
Yes. Remove it, please. And then I'd like to have Sion.
Sion. Normal Sion.
2 ml syringe, please.
Sion.
Yes. Okay, let's see now what we have here. Can you come to Areo now to see the connection better? Yes. Okay. More Areo. Yeah. Less cranial. Okay, so this is the third one. Let's see carefully which one is goes and where. Frame by frame, please. I think, yeah, we will use frame by frame. Yeah, Sion, please. M yapalım. 2 gram. Can I see it, please? All right. So the connection, that one, we try. Yeah, we actually we will try. Okay, can I have a torque, please? Here. Let's try the one lateral. Oh no, I think not that one. The other one will be nice, I think. But to have it, I need the more curve. Can I have a test, please? Here. Test, please. You have. Test, please. Test, please. Yes, this one. This is the one I like to go. Yes. So we cross easily. Very happy. Can you go to LO, please?
So.
Now I have to. I cross the septal, and I like to cross with the corsair, of course. Okay. And we have a kind of occlusion there, I think. I don't know. It seems that it's open. Can you hear me now? Okay. So now I'm torquing and I'm pushing my corsair to reach distal, because the other step is, of course, to go more distal, to go distal CTO, distal of the CTO. The crossing is not enough for us. Slowly moving. I think we need to do something else because it's not easy to insert. It will insert, but it will take time. And because we engaged the left system, patient has pain a little bit. So I think we had better do ballooning there. 1.5 balloon, 1.5 balloon, long balloon, and trap balloon. Trap balloon, please.
Trap balon.
1.5 balloon, please. 20.
No, no.
Trap balloon.
Again.
Can I have a trap balloon, please? Then what we do, I will dilate and I will push my macro after that. Okay. Can I see it? Show me. Okay, so I have to go up here. Okay, go up 10. Good.
1.20 balon.
Balloon, please. 1.5. 1.5.
1.5 balon.
Ne? Şöyle misin? Hı? Yes. We will do dilatation. I think somehow, although we have flow to proximal, but we have some occlusion at the distal as well. We were not able to insert guiding more, and our support is not perfect. That's why we couldn't insert easily to Corsair, I think. Okay, go up 10. Yes, please, go ahead. Down. I don't think it will help. Yes, go up. I don't think it will help. Injecting nitro down. Up and down. Sorry, I don't think it will help to inject nitro through microcatheter for this septal because I have to remove the wire first, you know. I already cross it. 10. It's down. Okay, 10. Better to dilate all the way down. Yes, up and down. Down. Up and down, yes. 10. Yeah. Right. Up and down. Down. Up and down. Okay, down, yes. So now, I like to insert my macro again. Can I have macro catheter, please? And trap.
Trap balon. Trap önce.
And macro catheter. Okay, can I see it, please? From the proximal? Can you show me? Yes, good. 10, 10, 12. And then I like to have now ultimate Bros 3 gram to go retrograde. If I failed, I will go with Gaia second. Okay. You see how it's going now. Okay. So I am in down. So
Miracle.
can I have ultimate now?
Ultimate.
I like to do some injection here to see what's going on. Can yok mu?
No. More contracts. CT takip
Cam enjektör yok mu? Nereden? Nereden geliyor? Ha? Okay, yes, you see that there is a somehow occlusion there. Okay, my wire is now ultimate bros. Can I have a talk here? Of course, this patient is rather complex because it's osteocclusion. Collateral is good. We have nice collateral. That's the nice part of the case. Oh, aha! You see, it's right. This is Safari have more. This is good. Very good surprise, yes? It happens. So I have to check again. Okay. 3 ml stage, please. Okay. Hazırlayın bir tane. Okay, nice. So that's why we didn't have this. Okay, so let's have Sion again. No, we have Sion here. Can we have this image to there? Yes. So I understand now why we had this difficulty is to send Sion, because it seems that it's the CTO starts more proximal. So because we went the Safengraft. This is better now. Okay. So real CTO is here, right? According to Angio, it was the same here. So I have to cross this and then I can send my wire again, which is ultimate bros. Okay, let's have now
Okay.
tip injection first, and then
Elinizi kaldırın Necdet.
okay, we adjust up to,
Site function.
yeah. Let's come
Ultimate.
back a little bit, and yes, this is good. Let's have
Ultimate.
ultimate. We can give a chance to ultimate for a couple of minutes. If not, we will use Guy a second here. At the moment, we don't know where is the course of RCA, so we cannot go by. Can I hear the ACT?
310.
310. Okay, give 200 more,
Yes.
2000 more.
2000 daha yaparım der abi.
Okay. Can I see from the right? Inject slowly.
Maybe
Test, please.
not engaged.
Not engaged.
Yes.
Okay. All right. Our catheter is not engaged, and I think the vessel is around here. Yeah.
Yes.
Yes. I think I am in aorta. So we can snare this. But before snare, I try to insert this.
No problem.
I think I'm 100% sure that I am in the aorta. If you look my wire,
Yes.
if I cross this nicely, I'm very happy, because then I will snare my IG wire, which is the of course the best we could hear.
Guiding. Left guide.
Yes, guiding. We're almost there, but always the ostium
Guiding.
more calcified. We know that. And can I have a snare, please?
Snare. Snare. Guiding. Be careful. Guiding. Guiding.
Very
6 açıyoruz.
yok, büyük olacak.
Good.
Büyük. 30-35. You see that's not easy because of calcification of the ostium, I believe. What can we do? We can snare it gently. We don't want to snare the stiff wire.
Change this guiding or the same guiding?
Yeah, we can change the guiding. Yeah, true. Good idea.
Jotkins.
We will change our
Jotkins.
guiding as well to right Jotkins to to stand ostium better. Right Jotkins. Yes. Flash, please. Y connector first. Huh? Okay.
What's that aşağı?
Can you show us?
Yes.
Let's try to engage with this. I know, maybe I have a chance to go directly in the catheter with this RG test, please? Okay, can I have a test, please? By the way, this patient is chronic disease, chronic kidney disease, and twice in a week goes to dialysis. We did bilateral femoral injection in this patient. Test, please. I think we need to snare it.
Snare, snare.
Sometimes, of course, you know that it takes time. Not snaring easy. It looks easy, but most of the time not easy. Yeah, you know that. So, and especially for this stiff wire, we don't want to snare it. Yes,
Sol guiding.
it's important. We have to be very careful.
Sol guiding biraz.
The why, the problem is could be, and also we have to snare the soft part. Problem is we cannot release it.
Yes.
Yeah, I have it now, but I need more space here, like this. And then, yes, and push. Now you can push. No, you can push the micro. I don't want to give it inside. Just I like to, yes, try to, yes, yes. That's good, you know, because I didn't properly snare it. At the moment, I don't have any risk. Yes, it's already jumped. This is nice because sometimes we cannot release
RG.
the stiff wire. I like to have RG wire now.
Ready.
You can have this. Yes. So I like to have 2.5 balloon, long balloon here. And I think to see the RCA, it's better to use IVOS. What do you think?
Yes.
No, I don't have anything. What do you mean fracture wire?
Fine is a guiding.
This is RGR. I change it to RGR now.
Yes. Yes.
Okay, let's, yes, hold it please. Yeah, I will be with you. I like to concentrate now. Better to,
Yes. Tel göster yukarı.
okay, and then,
Tel.
okay, nice. Okay, now we can remove the RG. We have better to disengage this. Okay, now I like to have my wire. I don't know if it will come. I don't know, it will not come. Okay, but I can push it. I can push it. Yes, I cache, but you see that, okay, can I see other? Yes. Okay, you can open it. Okay. So I'm pushing. That's good. Yeah. Now I try to insert RG wire to have from the other side. Okay. My colleague is waiting to have it. The first I snare it,
Yes.
and yes. Now,
Just one.
oh, I think you have seen that we have the other end. No need to cut, huh? Do you want to cut?
Yes.
Okay, cut it, yes. Because we snared it, Ahmed cut it to have better smooth end. Okay. So, do you have any questions so far? We did loop, and we will do dilatation, and after having IVOS, I'm not sure if you could see IVOS, this camera.
Yes.
More, yes. Okay.
Yes.
Nice. Okay. I am pulling a little bit back to Corsair here.
AST.
That's enough. I
AST,
can
AST.
maybe a little bit, even a little bit more.
Unutmayın AST.
2049'da
Okay. So, balloon please.
Balon. 2-0 ya da
2,5.
2,5 uzun balon.
20. 30. Do you have 30? Şey hemen cam enjektörü gelsin hemen arayın.
AST.
Aramıştır zaten şey.
AST.
Yes, we did. Do you see my hand? Right, I see. Okay. Okay. So I already snared and I read. No. Yes. That's
Because
okay.
the
We
wire
have
is
both
the side.
hands. Don't care. Sorry, but that's okay. Because we cut it, will not be easy to insert me. I may need the younger eyes. Oh, I did it. I did the RG wire because we snare it, and we had a kink. You know, the CTO starts like this, so I will do dilatation here. Yes, go up. Yes, 20. Down. And after that we give some nitro to see the distal and proximal size. Down. Up and down. 20. Okay, nice. Alright. Again, yes. 10. Down. So I like to have 3 or 48 stand, which will be size.
Some nitro. Pressure is good. Don't injection. No. No, we cannot inject anything, and we can better to release this. But we will do inject from the ostium, okay? Yes.
To see the ostium of the
To stand.
stent, yes,
Yes.
ostium placement of the stent. But we cannot inject anything. Nitro, nothing. And we had better see SCT.
AST. AST.
Benim ellerimi göremiyorlar mı kamerada? Bak bakalım. Göremiyoruz dedi demin RG'yi. Siz bakmıyor Bakıyor musunuz oraya ne gittiğine? Harbi hiç. So, I'm putting the longest stent I have. Okay, now I place this from the ostium and after trio. This is trio. I can expand this as much as I want, so trio is nice. Test for them. This is 48, so the only can you come to science? Yes. Spider. Spider. Yeah. Test. Test, please. Okay. Let's see some injection. Test, please. Slowly. Okay. Not much. Okay. Can I see it? No. Sine. Okay, I think that's good. Yeah.
More
A little bit proximal. Like this, I think that's good, yeah?
Yes.
Test please a little bit. Slowly. Okay, nice.
It's
Go
good
ahead.
now.
Go up.
Shish, shish,
10?
shish.
10,
Yes. 14, 16.
14, 16.
Down. So because we engage from the left, the patient has some chest pain, but after remove the guiding from the left, patient now feel better, of course. We can do some nitro. We see nitro after nitro and then sıvı verelim arkadaşlar. Sıvı gitsin, nitro verdik, sıvı gitsin.
Sıvı gidiyor hocam.
Ne kadar? İşte sıvı gitsin deyince full açacaksın. Ha, tabii ki sıvı gitsin o demek.
Tamam.
Sıvı zaten gidiyor tabii. Okay, let's see. Let's see.
Opak yok mu? Yes.
Okay, go ahead. Very nice. I think we did the CTO part, and this little part needs some massage and dilatation, I think. Yes, we will do it by 2O balloon. Or, yeah, 2O balloon first. Eleocranial, please.
Solid.
2-0-20 balon.
Eteği alır mısın oradan?
2-0.
Eteği al.
Göster.
Bir saniye.
Göster. Bir saniye. 2,5 da olabilir belki. Bir saniye.
Bekle.
Hop, air,
Yes, yes, yes.
air.
No.
Yes, air. Comes air, you see? You see? You said no, but we have it.
260 kilo asetil.
Kaç?
260 kilo.
Okay. So, we give more, huh? Test. Okay, nice.
2-0. 2,5 hocam.
Okay, we can do dilatation by 2.5
Masada var. 2,5.
and the ACT after how much we give? Yes, but before
Total
5,000.
yes, we did 13.
So are we sure that?
Yes, I'm sure. The first 10 and after that we did 3.
Okay. Let's see some dilatation. And to me, the proximal stent will be expand 3.5 because I see nice distal zone. Yapayım mı? Burası açık. Şöyle bir bakın. Okay, can I have a test here? Test. 2,000 more, yes?
Yes.
Okay. We gave 2000 more after 260. I think from here. Yes. Go up. 10. This is 2.520 balloon. 10, 14.
14.
Okay. Down. Fourteen and down.
14. Down.
14. Yeah.
14.
Okay. Down. Yes.
14.
What do you think for the proximal to 3.5?
Yes.
Yes, because it's big vessel.
Yes.
There are lots of branches. Yeah, but please say 16. Let's see the distance.
Yes.
Down. Let's see.
Oh, very nice.
That's nice. We can leave it like this, huh?
Yes.
But it's big artery, right?
Yes. That's one.
And let's do dilatation. And then we leave it like that. Let's see, by time it will be better. 3.5 balloon. So we have all side branches, everything.
No, we will see. But we will do now post dilatation or proximal stent, and then we will see.
We will not do dilatation, the stent too. I don't think we need it. By time, the vessel will be better. By flow. Hopefully. If not, we will see. LAO, please. Here, right?
Yes.
Go up 10. Yes, I'm in. I am in, right?
10.
10.
Yes.
14, 16, 20.
20.
So, this is 3.5 balloon. Yeah, 20.
16. 20.
Down. Let's make sure it's expanded well. 20.
16, 18, 20.
Down. 20.
20.
Down. 20 and down.
20. Down.
Okay, good. This is not test.
Yes.
But this part is under expanded. The distal part. Test it. I like this part.
Yeah. Yes, here. Yeah. No, no, not.
Here.
Yeah.
Okay, go up 20. This part is not expand well.
16, 18, 20.
Yes, we go up to 20. Yes, they said. Okay, let's have some nitro again and then we will see. After that we remove the, I'm removing my macro to prepare myself to retrieve, but yeah. Let's leave it like here. Eleocranial. Sorry? You want to do stent?
Post dilatation.
No post dilatation and this. I don't need this is necessary. Yes. Oh, I think that's good. We don't have to do another stent. What do you think, Naim? That's okay. That's okay. We can do, but let's ask colleagues. But still, this little part, I don't like this little part.
Yes, I think.
What do you think?
Another stent.
No, no, I'm.
Biliyorlar sen bilmiyor musun? Söyledik ya.
No, no, I'm not talking about that one.
In the stent.
Stent part.
Not bad.
But we did 20, so we can't use 4 there, huh?
Maybe.
I don't know. We can use. Epicranial. Let's see the distal part. Let's see if any big dissection something. That's okay. But this big vessel,
Yes,
if
and
you
for
look
this
the distal
reason,
part,
not small hair.
not small at
Yeah.
all. Very nice one. I think distal is okay.
Yes.
I think. So, Lebabe, do you think that we have to stand the distal? Eleo, please. Yes, we did dilatation, balloon dilatation, and I think it's okay. You know, we can call this patient sometime later. Yeah, definitely. It's okay. I think we can leave it like this.
Yes.
Do you want for all post dilatation? Ahmed, are you sure?
It's enough. 3.5. We did.
Yes, I don't like that. Yes, in this stand, right? Mid part. I mean, you mean the mid part of the vessel, distal part of the stand, right? Actually, we did 3.5 by 20. So, yeah, 20 atmosphere. If we do something more, we have to use 4.0. But I can use 4.0 because to me it's big artery. The mid part is a little under expanded. No, there is a. I mean, there is disease part for sure, but the flow is okay. We can put a stent. There is no dissection. If even there is a dissection, it will sealed to me. Yeah, I think yes. I think let's follow this patient after 3 months. Okay. I don't know. Bigger. What do you mean same size? You mean the? You mean it's where we did we didn't do flaring, but we did 3.5 20 atmosphere dilatation again 24. Flaring, yeah, we can do, but I don't think so. If it is that, it's not big, big diameter. Just only I'm thinking about for dilatation. I would feel better. I feel better if you do 4 balloon, yes. 4 balloon. Okay, let's do the gentle dilatation there. This is 4 of 15. Test please. I'd like to see the result. Yeah, test please.
Yes, yeah.
Here,
no
yeah?
problem,
Okay, let's
Sure.
do it. Just a second. Okay, go up. 10. 10.
10.
Slowly. Okay.
10.
Yes. 12. We go up 12. 12 is good. Because it's the large balloon down. Let's go up 40.
40.
Down. This is 15 balloon. Yes, down. Up and down.
15 down.
And we do flare as well here, as you suggested. Yes, up. 20.
14.
20.
20. Down.
No, no, no, no. Okay, down. Test please. Yes. Good. Eleocranial. We do dust injection before removing the wire. What?
Yes, yeah.
Go ahead. Okay.
It's enough.
For distal, I think. So what do you think for the distal? I think you want stent, right? The distal. Mid, I mean,
After stent.
after stent. Right. Okay. Huh? What is it? Okay. We agree.
Uç sıfır
3.5. No, but dissection could happen.
yeah,
30, 30, what?
33 or 26.
33.
33.
3 or 33 and we post dilate. Okay. Let's put another stent. .5 balloon.
Masada var ha.
Can I have some more? Yes, it's okay. I cross it. Sola doğru gelelim.
Sola.
Derin bir nefes alıp tutmanı isteyeceğim. Derin nefes al tut.
Derin nefes al.
Tut öyle ha.
Necdet abi.
Here. Test please. Tut. Test.
More oxygen.
No, it's here.
Yes, here.
Okay. Çık.
Şiş.
Hemen.
Şiş.
10.
Okay. 15. 16.
16.
Yeah.
I'm not sure if it is okay. Huh? We have to do
Down.
down. Maybe longer one. No? We did overlap much. Test please.
Oh, very nice.
That's okay, huh?
It's okay.
We will leave it like this.
Not anything. Only oscillation and we control a bit prograde because we did.
Okay, let's do dilatation and we'll leave it like this. Negative. Negative. Yes, go up.
Shush.
10, 15, 16.
10,
Down. 20. We did more overlap there.
10, 14, 16,
Down. 20. And we need for all for
16, 18.
Or this
Overlap.
version, huh?
overlap. Down.
Drop support. Drop support.
Negative.
Bu dialysis
So this is for ovalon to do overlap part dilatation because we implanted 3.5 inside furrow. Let's do gentle dilatation here. Okay, go up 10.
Shush.
Okay, down. Okay, another dilatation, nitro, and then we finished it. Let's see, just a second. Let's see. First, then I will do. Let's remove the wire. Then we may have. So I remove the wire now. You see that I can remove it easily like this. You see? I put my corsair into the stand to protect all side the everything. So I will check.
For them.
Yes, no, I want to check first that.
Yes. Yes, sir.
So let's check.
Not this. Burada hazır mı?
Let's check the left system.
Yes. Bravo.
What we have. Test please. Okay.
Kavdalga.
Yes. Right area please. And then let's see the septals
septal,
because we
yeah.
did some dilatation. I don't remove my corsair all the way because I may need it. Test please. Okay. Let's do tip injection. Better 2 ml syringe.
Yes.
Okay,
Okay,
nice.
okay.
So we have nothing. Of course, we have dilated septals, but they will be normal in 1 month.
Göster. Kavdalga.
They are not stay like that.
You can see the left column.
Yes, I have to see the left main before removing this. Test please. And left main is okay, I think. So, yes. Later on, we will work on the OMR and CIRC because we have bifurcated lesion. This patient had kibich operation, so and OM graft is occluded. We will do later on. So left system removed and array of cranial. This is the last image we will have before finish. Okay, go ahead. Okay. How do you think? I will leave it like this. We will see because there is a step down. Still, we have a
Another dilatation
for what?
for proximal part of the stent. Overlap.
Yeah, but I did for all. I think that's okay. Yeah, we did for all. We can't break the artery. Can you hear me, guys? Bağlasana.
Bağla bakalım. Tamam.
Bunu güzel koyamadın sen.
Tamam. Bırak.
I think we will göstersene niye başvuruyor.
Oyna.
So I like to show we will see it later on because I will do circ anyway. Then I will control this next and then I will explain everything from the beginning. So this patient had RCA occlusion. This is the left system. Patient had 65 years old patient. He had CABG operation 2003. Now only Lima 2 LAD is patent. The other graft is occluded and RCA is occluded from the ostium. If come back. This is the ostium of the RCA. Next, please. Of course, because we had ostium occlusion, we went primarily retrograde. Next, please. And this shows us.
Next.
No. This shows us the occlusion is not that long. You see that RCA goes to almost proximal RCA. Next, please. This is this is a spider view, and yes, this is. I think in here the third septal is our target. There are lots of collateral, and the third one is good one, we believe. Next, and we engage that one, and we did tip injection. We see that there is nice collateral. Yes, and then we cross it easily, but we couldn't. We couldn't send a Corsair. That's why we did pre-dilatation. Hiçbir şey kaydetmemişsin. And we did dilatation by 1.5 balloon. And after that, next please. No, wait.
There we go.
Come. And after that, we insert micro. Bekle ben demeden. Gitme.
Aynı şey.
This time you will see that the Corsair will cross easily because you already dilated it. You see how easily it goes. It didn't go before. We tried a lot. We spent at least 5 minutes but couldn't go. Next please. Unfortunately this one is, we see that this one is, the first we thought this is RCA, but it's, after that we find out this is saphan graft. Next please. And we, next please. We did tip injection and we find out that we were in saphan graft, and now we try to redirect our catheter. Next please. And again Sion help here, and then easily we went up and we push microcatheter. And here we use the first wire was Miracle Ultimate Bros. I like that, I like either Ultimate Bros or Gaia second for retrograde. Next please. Oh now come back, because I think this is whole. Okay, so whole story you will see it. Now while it's coming, this is Ultimate Bros. So it wasn't that difficult actually to cross the CTO, to be honest. And while it went that way, little high. So we thought that the side branch first, but after that we realized that the guiding is lower. The guiding is not sitting at the ostium. And then we just crossed the ostium and jump out to like this to aorta. This is definitely aorta. Next please. And then we tried to push micro, we couldn't. And we tried, we couldn't, and although we didn't recommend it, we just strap this strip wire. Next please. We just snare at the proximal, but we didn't kink it. We think that it will be dangerous because we cannot release the wire from the snare. This is the danger of this, step, because we shouldn't snare the stiff wire. We just snare it and we just keep it as a snare. We didn't, yes, like this. We didn't kink it. You see? We hold it there, and of course we had more support, and we were able to push our micro like this. Okay. So after that, we change our wire to RG. We snare it. Next, please. And this is RG snaring. Yes. Next, please. This is after looped. We have looped now, and we did predilatation 2.5. We can go fast now, because we did predilatation. We put first stent 3048. Next. Next. This is 2.5 dilatation. Next. Yes, this is the stent. We implanted from the ostium. Next, please. This is the stent is 3.5. 48. No, this is 3048 stent.
No,
Next.
3.5. What's your
No,
3.5?
30. Yes, this is 30. And we did post dilate by 3.5 first and 4.0 first. And this we put another stent, as you know. This was 3.0 by 33. So show me the last image. We did lots of dilatation. We did post dilate 3.0 stent to 3.5. So we have 3.5 distal, 4.0 proximal. After that, we thought that better to, this is 4.0 balloon dilatation. Next, please. Yeah, this is 3.0, 33, and we post dilate by 3.5. Next, please. Next.
Good again.
No. Okay. Next, please. Next. No, next. Okay, we check this septal. Septals are okay, dilated. We know that, but it will be normal in 1 month. Next. This is, we checked the left main. If something happened, nothing happened. And this is the last, it's big artery, to be honest, without question. That's why we dilated by 3.5 and 4.0 at this level. Thank you very much for your attention. Olsun, ne yapalım? Çakalım. Öyle mi? Sinüs müydü o?
Biraz su içelim istersen.
Ha?
Su içelim istersen.
Önemli değil. Sinüs mü o?
Sinüs de öyle.
Çakalım. Ya, ama döner bu ya. Dönüyor. Afiyet kalır.
Angiyosin. Görüyor musun sonra?